Today we have with us Brian Snelling, who is a neurosurgeon who is trained in doing both. So maybe he could, Brian, do you want
Sure.
to answer Alexandra?
Yeah, just just a quick background. I think I really appreciate everybody sharing their stories. It's always refreshing and inspiring to hear how you guys have come forward and shared really personal. I can tell you from the other side of the other side of the clinic room or whatnot. It's it breaks my heart to hear a lot of what you guys have gone through. I'm sure, as Pierre knows, when you do know about IIH, or let me rephrase that, like when you know as much as we know currently, which there's still more to be learned, and you see patients who have sort of bounced around from physician to physician, and they haven't really received a diagnosis. It sort of breaks your heart that people have gone sort of untreated. So I certainly understand that. And one thing that I always tell people, and this is why I think it's so much, you guys mentioned it's so important to be an advocate for yourself, that in medicine, a lot of times physicians are very siloed in terms of not only what they know, but also what they do. So if you go to see your primary care doctor, they're probably not going to know about IIH, right? It's just not something that they're going to understand. Certainly if they're older, and they've gotten out of med school, that's just not something that they may understand. And even, a neurologist, that may not be something that that may be something that they have some sort of cursory understanding of. But what are the latest treatments? Do you need to see a neuro-ophthalmologist? What do you need some sort of surgery? When do you say, okay, you're not tolerating Diamox? Those can all be difficult, so I think being your own advocate is unfortunately what often has to take place. Otherwise, you find yourself going from physician to physician until you end up seeing somebody who says, okay, well, I actually do know what's going on with you, and you have IIH and you need X, Y, and Z. You're going to have to get, lumbar puncture, this, and this, right? And then somebody finally tells you that sort of can get you started on the right path. Surgery wise, it sounds like there may be someone on the call who's had a shunt before, but a shunt is just, it's sort of what we neurosurgeons call a last resort for IIH. The problem, usually all shunting is just plumbing. It's plumbing that drains the brain and spinal fluid in a small tube that goes under the skin down to the belly. And it's been around since the 50s, and it's just some simple tubing and a little valve that you can change with a magnet. There's a lot of other illnesses and diseases that can result in overproduction of this brain and spinal fluid. That's called hydrocephalus. And that's usually what neurosurgeons place them for, is that your body makes about a soda can's worth of brain and spinal fluid every day, and you reabsorb it. You've been doing it your whole life and you never knew it. But when you make too much of this fluid and you don't reabsorb it fast enough, that fluid builds up, and then a shunt is a great way to fix that. So for a lot of people, it's a really great treatment. How that relates to IIH, though, is that as a last resort, one of the ways to reduce the pressure in the brain or in and around the brain is to remove this fluid. It's just one of the ways to do that. And it sort of does what Diamox is doing. Diamox helps you produce less of that fluid. Remember, you're making a soda can's worth every day and it's getting reabsorbed. So it helps you produce less of that fluid. But how the shunting works is the shunting just takes that fluid, takes it out of the skull, puts it around the belly. So it's not really solving what's caught the issue. And so I think that's where some people, that's why neurosurgeons like to treat that as a last resort, because it's an overproduction of brain and spinal fluid isn't the problem. And that's usually what we place them for. It can help. And how it helps is it usually can help prevent worsening of vision. So if someone were to come to see me in clinic and they had vision problems and they weren't candidates for any other sort of treatment and they'd failed medical therapy, shunting sort of is the last line of defense we have to save vision. And it can work for that. The problem is it doesn't solve all of the other problems that go along with IIH. It wouldn't solve pulsatile tinnitus. It wouldn't solve headaches, right? It really just manages to keep your vision hopefully where it's at, not let it get worse, but it may not even improve the visual loss you may have already had. The other you know, again, and if you've not seen a neurosurgeon before, we're often reluctant to place them. Oftentimes, when you're placing this tubing into the brain, the fluid spaces are pretty large, and they're easy to place, and the catheter can drain the fluid adequately. What happens in IIH though is that as that pressure increases in the brain, due to venous, an inability of the venous blood to return properly and whatnot, the fluid spaces actually get really small, and they develop sometimes what you can call slit-like ventricles. If you've had MRIs and you have IIH, you may have seen that on your MRI report. Oh, it says you have slit-like ventricles. What that means is now we have to place this tubing into a very tight space where the actual volume of fluid is very narrow. And all this tubing is it's simple plumbing. It's like the plumbing in your house, right? So it's in this patient cohort, in IIH patients, that tubing can break down quite frequently. In my experience, I've seen patients that have had shunt malfunctions where the brain collapses around the catheter because we're trying to do the best we can with what we have, and they need a revision surgery. So that can often be you get put on the path of getting multiple revision surgeries. Sometimes they work well, but sometimes it could be frustrating. So that's why we generally like to reserve that as a last resort. There are other options. There's things called optic nerve sheath fenestration, which is done by usually like a neuro-ophthalmologist. And as Pierre alluded to, there's venous sinus stenting, and that's something that's we're learning more and more about. That's taken more of a role in helping patients. And the thought is that by that, it's hard to know. I think Pierre, correct me if I'm wrong. Pierre's very humble. Pierre's a world expert in all of this. But it's hard to know whether the vein narrowing comes first or the vein narrowing is just a sequelae of IIH itself. But by opening the vein back up with a stent, you can dramatically reduce that pressure. So what will often happen is if you're determined to, you have venous sinus stenosis, you're determined to be possibly a candidate, the first thing you would have done is what's called venous sinus manometry. And a venous sinus manometry generally is it's where you have an outpatient procedure where they put a small catheter up, and sometimes they put the catheter in one of the arteries that delivers blood to the brain, and they take some pictures of the arteries, and the arteries drain into veins so they can look at the veins. But separately, they'll take a very small catheter and put it in the venous system and go up, and they'll actually measure the pressure around the different veins of the brain. The veins of the brain are called sinuses. That's very confusing, right? Because you're like, well, wait, isn't my sinus like what drains? Like it's my nose or something like that, but it's not. So sinus is a medical term that can mean two different things. It can either mean the sinuses in your nasal passages, but when you talk to physicians like Pierre and myself, that really becomes the sinuses is a medical term for the veins that drain the large veins that drain the blood from the brain back into the internal jugular veins of the neck. And so if that narrowing is there, we take a very small catheter and we navigate past the narrowing and we measure the pressure. And we say, okay, is the pressure high anywhere? Is it normal anywhere? And usually what we often find is that in patients with IIH that have had some sort of imaging like an MR venogram, veno meaning looks at the veins, or a CT venogram that looks at the veins, and they have that narrowing, we see what's called a gradient. A gradient just means on the side furthest, towards the top of the head, furthest away, that pressure can be high. And on the other side of the narrowing, that pressure comes back towards normal. So we know that narrowing is restricting the flow of blood back to the heart. And those patients, we know that if that gradient meets a certain criteria, it's in a certain location, that they would probably benefit from having a stent to open up that narrowing and normalize that pressure. So when you normalize the pressure in the veins, you've normalized the pressure in the rest of the head, and you can hopefully avoid having to have a shunt surgery or have some other procedure. But that's generally how that works. And like I said, if you think of those three sort of procedures as a bucket, meaning the optic nerve sheath fenestration, the shunting, and venous sinus stenting, that's sort of a bucket of what we would say are procedures or surgeries that are offered to patients that we say fail medical therapy. And so as we've had a lot of different inspiring stories that some patients do tolerate these medications, but a lot of times people don't. I mean, Diamox is old medication, and the doses sometimes that it requires to be effective can cause a lot of side effects that patients just quite frankly can't tolerate. So I don't know, Pierre, what do you have? Do you have anything to add?
Yes, I mean, actually, none of these treatment, medical or surgical, has any FDA approval. Diamox is approved for glaucoma, but is not approved for IIH. Same thing for the Topamax. It's approved for headaches, but not specifically for IIH. And neither shunt, nor optic nerve sheath fenestration, nor venous sinus stenting. There is no large studies. None of these three techniques have had any have been validated by a large what we call RCT, you know, randomized controlled trial, a large prospective trial. However, we are physicians, we do them, and we know that they do work, you know. So we use it off-label. It means that they are not FDA approved for this indication, but we will use it nevertheless. No, it's certainly time to do a study on that, but that will be for the future. It certainly doesn't concern us immediately.